to all of you. Today our topic of discussion is TAPVC, and I am going to discuss TAPVC in two parts. In part 1 I will discuss about history, anatomy, embryology and pathophysiology, and in part 2 I will discuss regarding clinical features and management of TAPVC. First come to the history of TAPVC. The term TAPVC was first described by Wilson in 1798, and first successful surgical approach was done by Muller in 1957, and that was done through a closed technique, and first open technique was done by Louis Virchow in 1956, and Barrow and Kirkland were the first person to repair TAPVC with CPB, and in that article they have described another technique which is called atrial oil technique for repair of TAPVC. And Dillard first described total circulatory arrest without CPB in TAPVC repair, and in their series result was good, and they have published it in 1967. And Palm and Garsoni, they have described TAPVC repair in infant patient with normothermic CPB. Now come to the embryology of the TAPVC. There are two hypotheses regarding TAPVC. In the 4th week of embryonic development, single embryonic common pulmonary vein is developed from the posterior wall of the left atrium, which connects with the lung bud, and they form the pulmonary venous chamber. And there is another hypothesis in which it is written that pulmonary buds enmeshed into the splanchnic plexus, and which is draining into the cardinal and umbilicovitelline vein, and primordial common pulmonary vein fuse with it, and pulmonary plexus is formed. And in the later part of the development, there is loss of the connection between splanchnic plexus, and if the connection is persisting, that may cause TAPVC. And now come to the anatomy of the TAPVC, and there are different classification to classify TAPVC, and most commonly used classification is Darling classification, in which they have described there are 4 types of TAPVC. Type 1 supracardiac, which is most common, and 45 to 50% of the TAPVC is supracardiac TAPVC. And in this TAPVC, all 4 pulmonary vein are draining into the common chamber, which is connecting to the vertical vein to left innominate vein. And there are, in type 2, there is cardiac TAPVC, which is present around 20 to 30% of the patient, and in this cardiac type of TAPVC, common chamber usually drain into the coronary sinus or to the junction of the RA or SBC junction. And in type 3 TAPVC, that is infracardiac TAPVC, which is 13 to 25% of the patient, and in that case common chamber with the vertical vein which is draining into the portal vein. And type 4 is mixed TAPVC, which is present in 10% of the patient, and in that case there is combination of drainage in supracardiac or cardiac or infracardiac. And in this picture we have described whatever I have told in the previous slide. And there is another classification that is called Smith classification, in which type 1 is supradiaphragmatic without pulmonary venous obstruction, and infradiaphragmatic with pulmonary venous obstruction. And Nail's classification basically based on the embryology, and type A is connection to the RA or right common cardinal vein derivatives in the SVC or azygous vein, and connection to the left common cardinal vein to in that case common chamber is connected to left superior vena cava or left innominate vein, and connection to the umbilicovitelline system. And Barrow and Edward classification, they have described 3 types of TAPVC according to the route. In 1A type is long route, that is ductus venosus, portal vein and IVC in abdomen and hepatic vein, and 1B is intermediate route, in which common chamber is draining into the left innominate vein, and 1C is the shortest route, and in this case common chamber is draining into the RA, SVC or coronary sinus. And Harlan classification, that anatomical and physiological changes in TAPVC. Number 1, level of the obstruction, A supracardiac, cardiac and intracardiac, and mixed presence or absence of obstruction and causes of obstruction like extrinsic, intrinsic or obstructed ASD. And mixed TAPVC is described in article that was written by Dr. Chaudhary et al, and they have described 15 types of TAPVC, mixed TAPVC, and most common type is left upper pulmonary vein, which is draining into the vertical vein, and other veins draining into the coronary sinus. And second most common is right sided vein is draining into the coronary sinus, and left sided vein is draining into the vertical vein. And Chaudhary et al described mixed TAPVC into 3 major types, like 2+2 pattern, means 2 pulmonary vein is draining into one chamber and 2 is draining into the another chamber, and 3+1 pattern means 3 pulmonary vein is draining into the one chamber and 1 is draining into the other chamber, and Bizier pattern. And in this diagram we have described 2+2, and right upper pulmonary vein and right lower pulmonary vein are draining into the coronary sinus, and left upper pulmonary vein and left lower pulmonary vein is draining into the left innominate vein. And right in type B, right superior pulmonary vein and right inferior pulmonary vein is draining into the SVC RA junction, and left superior pulmonary vein and left inferior pulmonary vein is draining into the vertical vein through innominate vein. And in type C, right upper pulmonary vein and right lower pulmonary vein is draining into the SVC RA junction, and which is connecting through the left side, and left superior pulmonary vein and left inferior pulmonary vein is draining into the coronary sinus. And in another type, right superior and right inferior pulmonary vein is draining into the inferior infradiaphragmatic connection, and left superior and left inferior pulmonary vein is draining into the ductus venosus and finally to the portal vein. And now 3+1 configuration, there are 6 types: right upper pulmonary vein, right lower pulmonary vein and left lower pulmonary vein is draining into the coronary sinus, and left upper pulmonary vein is draining into the innominate vein. And in other type, right upper pulmonary vein, right lower pulmonary vein and left lower pulmonary vein is draining into the SVC RA junction, and left upper pulmonary vein is draining into the innominate vein. And in another type, right lower pulmonary vein, left upper and left lower pulmonary vein is draining into the innominate vein, and right upper pulmonary vein is draining into the SVC RA junction. And other type, right upper pulmonary vein is draining into the SVC, and other pulmonary veins are draining into the coronary sinus. And in the later type, right superior pulmonary vein, right inferior pulmonary vein and left inferior pulmonary vein is draining into the coronary sinus, and left superior pulmonary vein is draining into the innominate vein. And in other type, right superior pulmonary vein, right inferior pulmonary vein and left inferior pulmonary vein is draining into the coronary sinus, and left superior pulmonary vein is draining into the innominate vein. Now this is the Bizier pattern. There are 5 types in this case, and right superior and right inferior and right middle vein is draining into the SVC RA junction, and left superior and left inferior pulmonary vein is draining into the coronary sinus. And in other type, right superior and inferior pulmonary vein is draining into the SVC RA junction, and left inferior pulmonary vein is draining into the RA, and left superior pulmonary vein is draining into the innominate vein. And in other type, right superior and pulmonary vein is draining into the RA, right inferior pulmonary vein is draining into the coronary sinus, and left lower pulmonary vein is draining into the coronary sinus, and left superior pulmonary vein is draining into the innominate vein. In other type, right superior pulmonary vein, right inferior pulmonary vein and left inferior pulmonary vein is draining into the coronary sinus, and left superior pulmonary vein is draining into the left innominate vein, and they are connected with common chamber. And in this type, right superior and inferior pulmonary vein is draining into the intracardiac connection through the IVC, and left superior and left inferior vein is connecting to the RE. Now come to the anatomy of the common chamber. Common chamber is normally located posterior to the left atrium. This is horizontally, long axis of it is oriented transversely, and in case of intracardiac TAPVC it may be Y-shaped, T-shaped or tree-shaped. Normally one vertical vein is connecting from the common chamber to the innominate vein or portal vein. Rarely two vertical veins have been described. Common chamber may be absent in mixed or cardiac type. Obstruction in supracardiac TAPVC. There are different level of obstruction. In pulmonary venous obstruction means individual pulmonary venous obstruction, and common chamber to vertical vein junction, that is the joining of the common chamber and vertical vein. In that part obstruction is present, and in another case the joining part between the vertical vein and left brachiocephalic vein, in that part obstruction is present. And vertical vein posterior to LPA, in that case vertical vein is compressed between LPA and left main bronchus, that is called vascular vice, and that is a rare presentation. And now come to the different mechanism of obstruction in cardiac type of TAPVC. In cardiac type of TAPVC, the venous sinus and coronary sinus junction, that junction may be stenosed, or coronary sinus ostium in the right atrium, that may be stenosed, and rarely body of the coronary sinus may be stenosed, and that is rarely described in the literature. And now come to the obstruction in infracardiac TAPVC. Obstruction may be present in the diaphragmatic orifice, that is the most common place of obstruction in case of infracardiac TAPVC, or near the joining of the portal vein or portal sinusoids or narrow connecting vein. Now come to the anatomy of the cardiac chamber and septum. Normally in case of TAPVC, most of the patient is having ASD or PFO. Rarely patient is not having any interatrial connection, and in this case RA is usually large and thick and LA is small, and posterior attachment of the septum is shifted to the left. LV is normal in most of the patient, and RV is hypertrophic and dilated in case of supracardiac and cardiac type, but it is not hypertrophic and dilated in infracardiac type. And pulmonary artery and pulmonary vein wall is thickened due to prolonged pulmonary venous hypertension. And there are different associated anomalies in TAPVC like VSD, PDA, TOF, DORB, interrupted aortic arch and small pulmonary artery. And TAPVC is commonly associated with heterotaxis syndrome, and 25 to 30% of the TAPVC are associated with heterotaxis syndrome, and in that case they are associated with atrial isomerism. Now come to the pathophysiology of TAPVC. Most of the patient present in the neonatal age with they are critically ill neonate, and they are presenting with tachypnea, and if this is not obstructed, diagnosis may be missed in the neonatal period, and presentation of TAPVC is usually from the neonatal age to the 6th decade. And in one case report it was published that TAPVC was repaired in a 64-year-old patient, and that is the eldest age of presentation in that is described in the literature. And normally cyanosis is present in TAPVC except there is widely open PDA or pulmonary venous obstruction, because cyanosis is unimpressive in that condition except these two conditions. Patient may present with severe metabolic acidosis due to pulmonary venous obstruction, and that may cause myocardial necrosis. And there are different differential diagnoses in neonate who are presenting with tachypnea like meconium aspiration, myocarditis, and respiratory distress syndrome. And right atrium is the most common mixing chamber. In the right atrium, blood coming from the left side is mixing, and there is equal saturation in RAPA and left atrium and aorta. And in case of obstructed TAPVC, the flow of the blood is like in the fetal period, like IVC, blood coming from the IVC draining through the PFO to mitral valve to aorta, and blood coming through the SVC is draining into the tricuspid valve into the right ventricle into the pulmonary artery. Systemic saturation is more in intracardiac than cardiac and supracardiac TAPVC. Systemic saturation is more common in infracardiac than cardiac and supracardiac TAPVC. QP-QS ratio is very important because that determines the saturation of the patient, and gradient through the ASD should be less than 3, and if this is more than 3, there is restriction at the level of the ASD. And obstruction may be anatomical or functional. In case of restrictive ASD, right atrial pressure increases, and that causes increased pulmonary venous pressure, and as a result of that pulmonary edema may develop, and pulmonary artery pressure and pulmonary vascular resistance increases because of that, and that may cause right ventricular failure and low QP, pulmonary blood flow, low saturation, and low cardiac output. There are different determinants of systemic blood flow in case of TAPVC, like preload. Proper preload is required for forward flow, otherwise patient may develop cardiac output. That's why in case of obstruction, preload is reduced. And LV function is also important for forward flow in TAPVC, because as LV is getting deoxygenated blood, so LV function may be depressed in TAPVC. And flow in systemic circulation may be through the ASD or may be through the PDA. In case of restrictive pattern, restrictive PFO or ASD, systemic flow may occur through the PDA. And there are different determinants of the pulmonary vascular resistance, like obstructed. In case of obstructed TAPVC, there is increased pulmonary venous pressure, and that may cause the increased pulmonary vascular resistance. And in case of mild or no obstruction, there is increased pulmonary blood flow that may cause histological changes in the pulmonary artery, and that may cause increased pulmonary vascular resistance. Thank you.